I now invite Dr. Margaret Jastreboff to deliver a lecture. Dr. Margaret Jastreboff has been involved in tinnitus research since 1984 and on a full-time basis since 1991 while working at University of Maryland School of Medicine. Her experimental work encompassed the study of mechanisms of tinnitus using molecular biology, pharmacology, and behavioral techniques, including testing drugs for their effectiveness for tinnitus attenuation. She has been involved in clinical work over 25 years as well, while working first as Associate Professor at Emory University and later as Visiting Research Professor at Towson University and currently in the clinic of non-profit foundation. After over 35 years in academia, where she was involved in basic science and clinical research, teaching AUD students and treating patients, she became a president of JHDF and a non-profit foundation decided to research and education in the field of tinnitus and decreased sound tolerance, as well as treating patients. She organized and was one of the lecturers in 50 courses on tinnitus retraining therapy in the USA and close to 100 courses abroad. She is a co-author of over 65 papers and 100 abstracts. In 1993, she shared with Dr. Pavel Jastreboff Robert W. Hawks Award for her contribution in the field of tinnitus. She received her PhD in biological sciences from the Polish Academy of Sciences and postdoctoral training in pharmacology and molecular biology at Yale University School of Medicine. With this introduction, I invite her to share the lecture. Thank you.
Just let me a moment to put on the proper screen. I have I apologize, but
we can see the screen, sir. Now it is fine.
You can just
we could see, okay, but now it went up again.
Okay, can you see the screen now?
Yeah, now it is opening, sir.
So it's just the first line.
Yeah, now it's perfect.
Okay.
Thank you very much for invitation, and I hope I will be able to bring some new information to all of you in respect to misophonia. So before I start talking about misophonia, I think it is worth talking a little bit about reactions which all of us, we have to different sounds. So everyday sounds are acceptable by average listeners, and individual preferences to specific sound or level of the sound does not affect our everyday life and everyday activities. And physical characteristics of sounds as well as non-acoustical factors influence human response to sound. What is interesting that even though complete silence is not existing in nature, many of us are seeking silence, escaping from everyday life, trying to reach certain level of relax and escape from everyday sounds. What is also important, particularly in clinical practice, to keep in mind that occasionally sounds typically acceptable or even not noticed by people can be perceived for some time as too loud, unpleasant, annoying, or uncomfortable. And this is absolutely normal. Annoyance caused by sound can be related to many different factors. Loudness of the sound, emotional reactions to sound, familiarity to sound, overall emotional status of the person, health status, stress level, perceived or real control of the sound, and some social elements, interference of sound with life activities. Problem with excessive response to sound is nothing new. Actually, it's known for years, but only recently the interest in this problem has increased significantly, creating good opportunities for people to do some research, clinical and basic science research. It is still challenging to work in this field since definitions describing disorders of sound tolerance are not really clear and many different terms are used and can be found in literature. So, based on what we read and based on many years of our clinical practice, we propose to define decreased sound tolerance as being present when subject exhibits negative reactions following exposure to sound that would not induce the same type of reaction in average listener. We also postulate that decreased sound tolerance consists of two components, hyperacusis and misophonia. And these two problems can actually coexist frequently together. Looking through literature and these different terms and considering that all of them have in general in mind decreased sound tolerance, there are many medical problems which list decreased sound tolerance as a syndrome of some medical conditions, such as acoustic trauma, migraines, some mental problems, Asperger, which is in the scope of autism, withdrawal from benzodiazepines, some genetic disorders, and so on. Patients are reporting many different sounds which evoke negative reactions. Some people are calling them triggers. They can be loud sounds and they can be very specific sounds, not necessarily very loud. So power tools, mechanical motor sounds, leaf blowers, shopping center, big malls, and from more specific type of the sounds, for example, a dog walking on hardwood floor, or someone breathing, swallowing, some eating sounds, or specific voices of people and children. Patients report many different reactions to sound, including annoyance, anxiety, depression, increased awareness of sound, pain, irritation, sadness, hopelessness, frustration, urge to escape, and you can read many more, and not all of them are listed on this PowerPoint. Decreased sound tolerance can occur with varying degree of severity and does not always require intervention. And people with decreased sound tolerance complain about many different problems. First of all, inability to enjoy many activities in life, decreased emotional well-being, physical discomfort, problems with concentration, sleep problems related to anticipation of being exposed to bothersome sound, and in case of phonophobia, fear of sounds. Individuals with decreased sound tolerance who are unable to tolerate these sounds usually are reaching some people from different subspecialties, otologists, neurologists, psychologists, psychiatrists, audiologists, and occupational therapists are among them. Before actually reaching for help, most of the people are engaged in some coping strategies, including covering ears by hands, using earplugs, earphones, asking if this is related to person asking to stop making the sounds, leaving the place where the sound is produced, mimicking bothersome sounds, sometimes singing along or repeating certain words, avoiding the person, avoiding places, and using music to cover these unpleasant sounds. So most commonly when people are reaching professionals, they are actually hearing some of this by people tried already methods of getting help. It means using ear protection, medical doctors prescribing frequently medications, mainly for anxiety and depression, not necessarily for the problem. Parents of young people are hearing he will or she will grow out of it, and actually the problem is frequently ignored. Specific treatments include exposure therapy, particularly in case of phobias, systematic desensitization, creating positive association and desensitization, different forms of counseling, alternative treatments, mostly focusing on relaxation techniques, biofeedback hypnosis, and during recent years, definitely cognitive behavioral therapy is one of the leading treatments. And for the last 25 years, we and other people as well are using tinnitus retraining therapy for treatment of hyperacusis. And during last 20 years, we also are treating misophonia. So they are definitely positive reports related to results of cognitive behavioral therapy. Mostly results which are reported in literature are produced by psychologists who work with the patients, as well as patients working alone by themselves with the guide and some help online. So the question which frequently audiologists have is really CBT a part in a scope of audiological practice? And this depends on different countries. In some countries, obviously, it can be used and audiologists can use it. In some other countries, actually, CBT is not in a scope of audiologist practice. Certain elements of CBT and certain elements related to counseling, obviously all of us are using, but it is not strictly formal way how CBT is performed. And the other thing is that audiologists have to answer themselves the questions. Are they feeling prepared to engage in this type of the treatment? And are they able to dedicate time to individual patients during this treatment? Nevertheless, I will concentrate in this presentation on the use of TRT for the purpose of helping patients with decreased sound tolerance, and particularly misophonic patients. So hyperacusis is present when negative reactions to sound depend only on physical characteristics of sound. The meaning of the sound and content in which the sound appears are irrelevant. Patients will react in identical manner to dishes clicking in a kitchen in their own house and in a friend's house, and they will react negatively to all other high-intensity sounds. And TRT and desensitization offers successful treatment for hyperacusis, and we see in many patients complete removal of hyperacusis and bringing them back to normal everyday life. During tinnitus, we recognize that while 60% of tinnitus patients exhibit decreased sound tolerance, majority of them significant proportion of them react only to specific patterns of sound. frequently, not always, but frequently associated with specific situation, specific place, or specific person. For example, the music played by the child at home is not inducing any reactions, while neighbor playing same music is bringing annoyance and problem. Sounds of eating, chewing, swallowing, or breathing of close friends is not bothersome. On the other hand, the same type of the sounds at home from brother, sister, mother, or father are causing the problem. Voices of specific people. Clicking sound, for example, copy machine in an office is causing the problem, but similar clicking sounds in different place is not noticed even by the patient. So at the same time, patients who are reacting to this sound can tolerate sounds which are much louder, for example, loud music. So we could not really associate this phenomenon clearly with whatever we were observing in tinnitus patients. So the conclusion was we have to look for some name of this problem, as patients were looking to be labeled, to be able to say, I am experiencing this particular problem. So we asked for help. Guy Lee Don of Cambridge University, who was an expert in Greek and Latin literature, for prefixes and postfixes which the best would describe whatever we observe with patients, which now we are calling misophonic patients. Patients who have negative response, negative reactions to sound. And out of the list of prefixes he sent to us, we choose word prefix miso, which in Greek means hate, but misophonia must not be literally translated as a hatred of sound, but as an indicator of any type of negative reaction to specific or given person pattern of sound. Similarly, if you will be not translating photography as a drawing with light. So this is the same way of thinking about choosing and creating this word. More or less at the same time, Marsha Johnson started introducing the term of soft sound sensitivity syndrome, or 4S, which she later on renamed as a selective sound sensitivity, which partially addressed the issue, but is not pointing out responses to sound produced only in specific place or by specific person. So misophonia is present when an abnormally strong reaction occurs to sound with specific pattern and or meaning for given individual. Reactions may depend on the environment when offensive sound is presented, and physical characteristics of sound are only secondary. And indeed, the strength of misophonic reactions patients is only partially determined by physical characteristics of sound. So the person with misophonia will respond strongly to soft sound with specific pattern, but not react to other much louder sounds. Individuals may react to a given sound in one setting, for example at home, but will be not reacting in the office. The patients may react to the sound produced by a specific person, but not necessarily by the other person. So patients' negative reactions to the sound depends on non-auditory factors, such his or her previous evaluation of the sound and belief that sound potentially can be threatening. So phonophobia is part of misophonia. Then this negative reaction include fear of sound or exposure to sound which potentially they believe could be harmful. So sound frequently is associated with previous negative experiences, and patient's psychological profile and content in which sound is produced are important as well. So summarizing this divagation, we can create two different types of definitions for hyperacusis and misophonia. One related to behavior and the other one mechanism-based. In case of behavioral definition of hyperacusis, we believe that negative reactions to sound, which depends only on its physical characteristic and meaning of the sound, is irrelevant, would be a definition. In case of misophonia, negative reaction to sound with a specific pattern, meaning physical characteristics are secondary. In case of mechanism-based definition, hyperacusis reflects abnormally strong activity of auditory pathways to sound, which only in turn yield activation of limbic and autonomic nervous system, whereas misophonia reflects abnormally strong reactions of autonomic and limbic system resulting from enhanced functional connections of auditory system with autonomic and limbic system for specific to a given patient's pattern of sound. And again, from accumulated clinical data, we know that both problems, hyperacusis and misophonia, can exist by itself, but in most instances they coexist together. Particularly in case of hyperacusis, a significant hyperacusis is always accompanied by misophonia. Misophonia sometimes, and more frequently than hyperacusis, can exist by itself. It's also interesting, we observed this in our clinical data from 30 years ago, that the treatment for decreased sound tolerance without differential diagnosis between hyperacusis and misophonia were not always as effective as we would expect. Considering that negative reactions reported by both hyperacusic and misophonic patients, which I was talking about earlier, are very similar and patients' complaints are practically the same, the question is how to differentiate between these two problems. So the good question for audiologists is, how can audiologists help in evaluating decreased sound tolerance, in differentiating between hyperacusis and misophonia, and providing the treatment? We have extensive case history, audiological evaluation, counseling, and sound therapy. So typically patients combine and confuse these two problems. Loudness discomfort level are not sufficient to diagnose hyperacusis, but they are necessary to exclude hyperacusis from misophonia. Detailed interview is present, and in practice, these two problems exist together to varying proportion, and patients with significant hyperacusis, misophonia is automatically created as normal sound will evoke discomfort. Therefore, they would create a condition reflex. And once misophonia is established and the reactions are governed by principles of condition reflexes, the reactions will be very fast. They will be occurring without any thinking and without analysis of meaning of the sounds or belief related to sound. Before I talk a little bit more in detail about formal things, I think it is good to just very briefly review a few cases at the initial interview. So case one is a male, 27 years old, with normal hearing and healthy. Whatever I will is in quotation, they are exact words of the patient. It started at age 8 from sound made by older sister. Bothersome sounds included chewing gum, lip smacking, slurping, sound of kissing in the air by other people. He stated later on that gradually problems increased and even himself producing similar sounds was bothering to him. Maybe a little less, but still bothersome. And he reacted to it, and he stated from within. He also started reacting in expectations to hearing these sounds, and any visual cues start triggering his reactions as well. He was treated by pediatricians, by psychologists, and during recent years he also engaged in some newer approaches to misophonia, but unfortunately without success. Jumping ahead, he is one of our successful patients with TRT. Case 2, female, age 16, normal hearing and healthy. It started 4 or 5 years ago. The grandfather moved to the house. He had dentures and was making noises when he was eating. This was a beginning. Gradually, reactions expanded to other family members, particularly a mother, and other sounds like swallowing, eating popcorn. She did not have problems with the sounds when she was with friends. She was put on a serotonin uptake inhibitor to help her anxiety and take edge out of her reactions. At the end of the treatment with TRT, she produced brochure for future patients describing her experiences and telling other people that help is available. Another case is 46 years old with mild high-frequency hearing loss, not bothersome tinnitus for years. It started about 6 years ago. Please notice, it did not start in childhood. It started 6 years ago from expected testing of smoke alarm at home. Now, any alarm signal, even from the distance, induces strong autonomic responses. On the other hand, he likes loud music, events, and has no problem with flying. He tried treatment for phonophobia. For a number of years, he was also working with occupational therapies with desensitization, but actually he claimed that situation got worse. Again, he's one of successful patients. Female, 72 years old, high frequency hearing loss, no tinnitus, introduced to hearing aids 5 years ago. What is interesting, she stated, I was bothered by typewriter and similar tapping type of the sounds as long as she remembers. It was not a loudness, but how the sound sounded. I'm using hearing aids when I cannot communicate at all, but not using them as tapping sounds are even more intrusive. My audiologist said that I do not have hyperacusis and I have to get used to it. So she was trying to cope. And again, another successful patient. And the last case, female, age 29, with normal hearing, Asperger syndrome, diagnosed at age 19. She was a college student. All eating and breathing sounds were bothersome for her. less problem at home, a lot of problems in dormitory, food courts. I was always like this. Even smell of some food induces ear reactions, tension and pain. She probably had also tensor tympani syndrome. Occasionally, a TV food commercials giving her visual cues induce her reactions. She was engaged particularly in avoidance and sound therapy related to overload, sensory overload performed with help with occupational therapists. Why I show you these cases, you will find a lot of information in literature which is going completely different direction than what we are observing and what we are classifying as misophonia. Misophonic reactions are not only to soft sounds. Misophonia affects not only people of young age, but also older people. Misophonia triggers are not only related to eating, but to many other sounds, including louder sounds. So, what we are focusing at during interview? First of all, consistency of relation between the extent of negative reactions evoked by bothersome sounds and their spectrum and level. We are observing if reactions to the same sounds are the same or different in different situations. We are looking at type of sounds which cause negative responses. We are monitoring activities which are affected by sound and considering coexistence of some psychological factors or psychological problems and some tendency of particularly young people of tendency to control environment. We are using forms for structured interview, which briefly I will show you in a moment. At first, I want to mention to you that misophonic patients are often not understood by others. Their problems are very specific and they want to describe them to you. They want to talk about reactions they experience and they want to describe triggers which they notice. They strongly believe that this is important information to you to provide them with help. But there are also some people who cannot identify or remember how their reactions start. They know that they react to some sounds, but they don't have any past association. Untreated misophonia frequently is getting worse with time. So, in this form, which I will show in a moment, we have 5 main helpful questions which are allowing us to large extent to identify misophonia. The first question, is your tolerance to sound the same as people around you? You are not asking patients, do you have decreased sound tolerance? Do you have hyperacusis? You try to ask the question in unbiased manner. Is your tolerance to louder sound the same as people around you? Is your tolerance to specific sounds the same as people around you? Is your tolerance to sound in specific situations, specific place, the same as people around you? And finally, is your tolerance to sound associated with specific person or specific people the same as other people around you? And this is part of this structured interview form, which include also questions related to tinnitus, which is not topic of this lecture, but nevertheless you can see the questions which are listed above, and then later on there are questions related to favorite sounds, which are important. It's important to identify because we will be using them during some exercises with sound and using 4 protocols for misophonia. We also are asking about activities which are affected by this unwanted bothersome sound. And we have also a rating on scale 0 to 10 of loudness, annoyance, it would be great to have a good questionnaire which would differentiate between hyperacusis and misophonia. Unfortunately, there are none of the questionnaire existing right now is allowing us to differentiate between these problems. The questionnaires which I listed for you, we tried, but we are not using because they are not bringing us any additional useful information which we can use during treatment and during counseling the patients and look at the outcome of the treatment. But you are very welcome if you want to try to use them. Audiological evaluation includes pure tone audiometry, tympanometry, otoacoustic emissions, and loudness discomfort level. Please notice, we do not have any sounds which include really loud sounds. And if you look at loudness discomfort level at this graph, you can see that in case of pure misophonia, LDL's value can be as low as 30 dBHL and be as high as 120 dBHL. So this is not really a criterion for differentiating between misophonia and hyperacusis, but hyperacusis would never be part of this phenomenon if loudness discomfort levels will be a normal level. Misophonia treatment in TRT always consists of two parts: counseling, which is based on neurophysiological model of tinnitus, and sound therapy. So it is proposed that the neuronal networks involved in tinnitus and misophonia are basically the same and involve auditory system and its connections with various other parts of the brain. The difference between tinnitus and misophonia is that tinnitus-related neuronal activity is generated within auditory pathways, while in case of misophonia, it is created by bothersome, external bothersome sound. Mechanisms of tinnitus and misophonia involve pattern recognition, with crucial role played by subconscious condition reflexes, linking auditory system with other systems in a brain, particularly limbic and autonomic nervous system. And if you look at these diagrams, you can see that practically responses of misophonic patients and tinnitus patients are the same. The only difference is that the source for tinnitus is someplace, probably in the ear, whereas in case of misophonia, it would be external sounds. And connections for both misophonia and tinnitus follow pattern recognition principles. So TRT is a clinical implementation of neurophysiological model, and the final goal is to remove habituate reactions evoked by tinnitus, and in case of decreased sound tolerance, evoked by external sound. Habituation of reaction to tinnitus, or in case of misophonia to external sound, is achieved by combined synergistic action of retraining counseling and sound therapy. So a modified version of passive extinction of condition reflexes is implemented, and it consists of a simultaneous decrease in the strength of negative reactions evoked by tinnitus or by misophonia achieved by counseling, and decrease of strength of misophonic related neuronal activity by increasing the level of stimulation with sound in sound therapy. Sound therapy in misophonia includes enrichment of background sound and specific sound protocols, exercises with sound. All patients are advised to avoid silence, and sound enrichment is provided similarly as for tinnitus. I will be not repeating this. Sound use in sound therapy should never evoke annoyance or any kind of discomfort or any kind of the problem. Any negative activation of limbic and autonomic nervous system will be enhancing conditional reflexes and negative responses to sound. So why to use ear-level instruments in case of misophonia? You don't have to use, but we found that this increased implementation of sound therapy and compliance of the patients. Patients feel in control. They use stable sound source level, and they know they can increase the level of the sound when they are expecting or they are in surrounding with bothersome sound. In case of patients with hearing loss, we are using combination instruments, and we can help in training to hear phenomenon, while at the same time we are using sound generators. There are four main protocols which are used with misophonic patients. First protocol include listening to the sound with specific time, listening to music favorite sound, where patients have full control over the volume of the sound. The second protocol is very similar, except that control over the level of the sound is in hands of someone who knows the person very well. So the person is setting up the sound at the level believed he or she believes that the patients would like and feel comfortable. Then patients are advised to go to places where they do not have control over the sound, but places which they like, places like going to movie theater, or some heavy shoppers go to shopping mall where there is plenty of sound, there are food courts, there is music, and so on. They do not have control over sound, but at the beginning, if they don't feel comfortable, they have a right to move away, but we are asking them to try to come back again. And finally, protocol number 4, which is based on concept of complex condition stimulus, creating such a stimulus by combining sound, which has strong positive connotation, with offensive sound, and gradually decreasing level of positive sounds. So effectiveness of TRT for misophonic patients is about 83%. We took 200 patients, consecutive patients with decreased sound tolerance. 184 of them were diagnosed with misophonia, with or without hyperacusis. And effectiveness for cases with hyperacusis but without misophonia were similar, 83%. So 152% of the patients got relief of their problem. So in conclusion, combined counseling and sound therapy based on tinnitus retraining therapy offers successful treatment for misophonia. The treatment has to be tailored to needs of individual patients. The treatment takes time and required patient active involvement, but do not require frequent visits. More or less, treatment for misophonia is as long or even a little longer as for tinnitus. Misophonia may affect people of all ages and both sexes. It is more frequent in people with normal hearing and younger people, but it is also in elderly and people with hearing loss as well. Misophonia often accompany hyperacusis and tinnitus, and TRT is allowing us to treat all these problems at the same time. We are helping people with hearing loss, with tinnitus, with hyperacusis, and with misophonia. Thank you very much. and I am ready to answer some questions.
Thank you, Dr. Margaret, for the wonderful talk. And now I'm posting the quiz over here. You can please answer. And if there are any questions, please post it in the chat box. The first question is there any specific management for children having misophonia?
Can you repeat? I did not hear you.
Is there any specific management for children having misophonia?
Yes. Actually, a very important part of the treatment of children are parents. In reality, children are responding very, very well. Obviously, you are using very simple language, but if children are suffering because of this problem, they are following our recommendation. The problem usually starts with the parents who frequently know better, or they are trying to protect the child. So proper counseling and understanding of the problem by the parents is very important. It's also interesting, and at least I am allowing children to draw the pictures. And frequently they do not know exactly how to explain their experiences with misophonic triggers, but they wonderfully draw what they are feeling and what they are experiencing. But there is no any specific protocol. It is a counseling. The exercises with sounds, I like very much if they do voluntarily, not pushed by the parents. And from our experience, children are doing wonderfully well, including autistic children with whom we may not have actually possibility to converse, who are nonverbal.
Thank you. The next question is, can misophonia be also associated with traits like personal hatred towards a person, dislike to work? For example, I do not like typing, so I dislike typing sound. I do not like certain person, so dislike his or her voice and any other voice resembling.
I would classify these things as psychological problems. And probably if I would have this type of responses, I would ask the person to seek help of psychologists who will guide with this type of the problems. It might be some element of misophonia as well, but I think psychological aspect of this type of cases is, I think, more significant.
Thank you. The next question is, how can one surely diagnose when misophonia coexists with hyperacusis?
To tell this in the simplest manner, I would tell like this. If you have doubts, if there is hyperacusis and misophonia, you would not hurt misophonic patients treating hyperacusis as well. On the other hand, you would not get successful treatment for hyperacusis if the patients have misophonia as well. And we have examples of patients like this who, before the treatment was designed and recognized, the problem recognized, who were treated as hyperacusic for 7 or more years without any success, while following protocols for hyperacusis.
Okay, the next question is, when visual stimulus is inducing misophonia, how is TRT given in such case?
Can you repeat beginning of the?
Yeah. When visual stimulus is inducing misophonia, how is TRT given in such case?
Okay, obviously, first we are starting with sound type of related things, but let's imagine that this is, it came to me at this moment not visual, but actually tactile and smell stimulus. A child who had a problem with crackling sounds, particularly cookies, which were breaking. But on the other hand, he loved cookies and he loved smell of the cookies. So the mother started to bake the cookies, at first soft cookies, with the child, while also in the meantime producing some sound, additional sound. And the child was engaged in doing the things, positive things, which he liked, and gradually the cookies were harder and harder and harder. So in case of any additional stimulus, smell, taste, visual stimulus, you would be gradually engaging in exposure to this type of stimuli. Visual stimulus. It came to, I remember the lady who had a problem with blinking Christmas lights. And any blinking, then blinking lights start to be annoying to her. But we started from driving from the distance with dark glasses and whatever other problems she had, and she was observing this sound, these lights, and having her favorite music playing in a car. Gradually, she was engaging in more and more this type of activities.
The next question is how to differentiate misophonia versus phonophobia.
Phonophobia is part of misophonia. It means negative reactions described by phonophobic patients are fear type of reactions. So phonophobia is a type of misophonia. So you are differentiating, or not differentiating, but this particular type of misophonia is characterized by description of the patients who are talking about sounds which are fearful to them. And the treatment would be pretty much the same as I described for other misophonic patients.
We have one more last question. Are use of ear protectors recommended? If yes, how can we make sure it does not aggravate in future by increasing the perceptual sensitivity?
You asked the question if the ear protections are recommended, correct?
Correct? Yes. Are ear protectors recommended? Yes.
Ear protection is always recommended with loud sounds which can cause damage to your hearing. So whenever you are using power tools, whenever you are working with loud machines, you should use ear protection. In case of misophonia, we are gradually weaning out people out of overprotecting, just in case protecting their ears in expectation of exposure to bothersome sound. And some people are pretty persistent, but in case of people who are using ear level sound generators, they actually are providing this protection which people are looking for, because due to the fact that we are allowing them to increase volume of the sound when they are going to places where they expect loud sound. And it works very well, and they are learning extremely fast and not abusing this advice. Oh, the other thing is we are also talking to patients about auditory toughening or auditory conditioning. It is important to know that if we are overprotecting the ears from sound, what is happening, that sensitivity to sound is growing. So there is a huge volume of literature from Karolinska Institute where they are studying effect of low-level sound exposure to create actually protection against the sound. So again, the use of sound generators and proper explanation to patients about this phenomenon is very useful.
We have one more last question. Ear protection versus sounds desensitization. Which is better line of treatment?
Desensitization we are using for hyperacusis. And this is definitely the way how it is done for a number of years. There are many different protocols. And we are, again, this is a separate topic, but we are allowing people to set sound level at the most comfortable level and teaching them how to gradually increase level of the sound of sound generators in their surrounding. But there are many different protocols which other people are using, particularly occupational therapists, which if patients do not have misophonia, can successfully help hyperacusic patients.
Thank you, Dr. Margaret, for your wonderful talk and answering all the questions. Thank you for being part of this webinar.
Thank you very much, and I wish all of you good health and everything the best.
Thank you.